Hello, I'm Bob Challoner, the Chief Administrative Officer of Stony Brook Southampton Hospital, and I'd like to welcome you to another edition of Focus on Stony Brook Southampton Hospital, your monthly program about the people, the services, and the events at your local community hospital. And today we've invited Dr. Naso, Dr. Kristin Naso, who is one of our gastroenterologists to the program. Dr. Naso has been on staff for quite a while and a very, very well-known gastroenterologist in the community. And we're very, very lucky to have him both here at the hospital and serving the community. Today we're going to talk about colon cancer. And March is Colon Cancer Awareness Month, and it's a cancer that many of us frequently aren't thinking about. We always hear about lung cancer, we may hear about breast cancer, other cancers, and colon cancer is actually a fairly common cancer in this country. And we're very lucky to welcome Dr. Naso to talk about the treatment, diagnosis, treatment, and opportunities to prevent colon cancer. So thank you, Dr. Naso, for being with us today.
Thank you for having me.
Yeah, and thank you for being on our program and all you do at the hospital. Now, you work in Meeting House Lane, part of the Meeting House medical practice, but you've been on staff here at Southampton for quite a few years. I probably won't want me to say that number, but I know a number of years, and I've really been a mainstay for gastroenterology practice here. And I'd like to, maybe if you could just tell us a little bit about yourself and how you ended up out here in the East End also.
Sure. Well, I'd be happy to say I have been out here for 25 years.
Right.
Initially the first 19 years on the solo practice, and now the last 6 years part of Meeting House Lane and Southampton Hospital, and now Stony Brook Southampton Hospital conglomeration.
That's right.
It's been a lot has happened over the years from all kinds of different things, and like I say, today we'll talk about colon cancer screening and colon cancer itself.
Great, wonderful. And can you, people are always interested to how doctors end up in all the various specialties, and just what you had to go through to become specialized in gastroenterology, and then why did you choose that specialty?
Well, it's interesting. Initially I wanted to, at least I thought I wanted to be a surgeon.
Okay.
And my first surgical residencies, that's after 4 years of college and then 4 years of medical school, and then you get into residency, and during the residency period you have to make a decision, and I thought I wanted to be a surgeon. But my first surgical, which I took right out of the gate, I kind of I realized it wasn't for me.
Right.
And for me, this was, where I could still use my hands with procedures and be involved with that kind of thing, and not just do straight internal medicine.
Right, wonderful. I know that that's a field that there's often a shortage of gastroenterologists in communities too. So we're glad that you've ended up out here. So let's talk a little bit about just the specialty also, gastroenterology. What parts of the body and does a gastroenterologist deal with?
Well, it's interesting. Most people don't realize that we pretty much take care of everything from above the pelvic bone to below the breastbone, which includes the liver, the pancreas, the gallbladder. We don't do surgery on those areas, although now endoscopic procedures are becoming very advanced, where we are starting to do, not myself, but much more advanced specialized treatments where we're taking things away from the surgeons because everything is kind of being done from the inside.
Right.
So the pancreas, like I said, the gallbladder, the liver, the large and small intestine as well.
And so much of your work, I know, is done with these endoscopes, without cutting. It's really quite an amazing specialty at this point with some very sophisticated equipment you're using.
Yeah, I mean, it's just pretty soon there's going to be very little being done these days that's not being done from the inside, whether it's by a surgeon or by a gastroenterologist, because it's been shown to decrease the morbidity, mortality. People are able to get home sooner. The smaller the incision, the better that patients do, and the quicker they get returned back to their day-to-day living.
Absolutely, thank you. So we're going to talk today about colon cancer. And I know that sometimes people think about, especially we become a certain age, and we'll talk a little bit about your advice for screening and things, but sometimes we don't like the idea of having to go for that colonoscopy, but it is so important. And we also know that this is a real issue, colon cancer. And I'd like to just start off a little bit. There's different types of cancer of the colon, colorectal cancer, there's colon cancer and rectal cancer that we're screening for. And could you just describe what are the differences and what's happening?
Really the difference is just anatomical. Colorectal or colon cancer is pretty much the same in respect of how it's treated. The one difference is rectal cancer, which just on the schematic, we have the rectum down here and the rest is the colon, whether it be descending, the transverse, or the ascending. Rectal cancer, though, is just down here, which is the shortest portion, right before our stools are eliminated. In this area is treated differently when cancer is found. We usually start with radiation and chemotherapy to shrink those lesions to try to preserve the sphincter function. Whereas colon cancer in the other areas higher up, usually the patients after a workup don't need chemo or radiation. Initially, they'll go right for surgery. Put the patient back together, and then depending on the degree of how advanced the cancer is, then they might get chemotherapy. So it's just the opposite with rectal cancer, where patients get radiation and chemo first to shrink that lesion to allow it to be a little bit more amenable to removal and preserve normal bowel function.
And the radiation is done at a cancer center typically?
Yes, usually it's usually 5 to 6 weeks, and that's done, and then maybe chemo. And then the surgeon, after everything is calmed down inside, they'll go in and actually remove what's left.
Now I read that there's 200,000 cases or so in the country a year, so this is a cancer that's probably more common than most of us think about. And I guess the first question I would have for you is when should someone get screened for colon cancer?
Well, that's actually the biggest news that's happened in the last 6 months. In the last 6 months, back in September of 2018, the American Cancer Society came out with new recommendations. Prior to that, anyone over the age of 50 would get screened, routine screening. In other words, no family history, mother, father, brother, or sister, with colon cancer or polyps.
Everybody over the age of 50?
Except African Americans. African Americans would be started at 45. And that was well known, been that way for 15, 20 years. The problem is the incidence, we've noticed in the last 20 years, the incidence of cancer, how often it occurs, from 50 and older has been decreasing over the last 20 years, thanks to colonoscopy. Get those precancerous polyps out. If I took a polyp out on you today, at the age of, say, 50, if that polyp wasn't removed, say at 60 or 70, you'd have cancer. So it takes a little bit of time to see that drop, and colonoscopy's been out for many, many more years than 20 years, but we've been seeing a consistent drop on the 50-year-olds. The problem is from 29 to 50, we've seen an increase. So now between 29 and 50, 10% of colon cancers are in that age group.
Oh, really?
So because of that increase, and it's been going on for some time, the American Cancer Society came out and said now everybody, starting at the age of 45, should be getting routine screening colonoscopy.
Oh, wow. That is brand new.
As of this September. And then there was some concern whether insurance companies are going to jump on board, because just because it was put out there, are they going to pay for this extra amount of care?
That's right.
And it seems they are, because I've had, in that time period, the word is getting out slowly that people should now not wait until 50. And we have been successfully getting it reimbursed. I mean, I had a patient, 29 years old, the other day, probably about 3 weeks ago, 29, had bleeding for a year, which he thought was hemorrhoids, came in, and I found a cancerous polyp in this young gentleman. We then did genetic testing on him. Right there in the office, you spit in the tube, you send it away, kind of like 23andMe or other those genetic
services.
Not that that's any better than the old others out there. And it came back negative. So he didn't have a genetic predisposition, and here is this young man at 29 who, at 35, he would have had full-fledged cancer. We were able to take out the polyp, he's a cure. But that's really kind of scary that someone this young, without a genetic predisposition, would have had cancer at 35. So this is what went into this, not that case specifically, but cases just like that went into the decision by the American Cancer Society to change the recommendations.
I guess the thought probably is the type of screening you do. I mean, all medical procedures involve some risk, but the risk benefit must be greater to just start doing it on more people. So.
Right, and especially the risk drops as the younger you are. The risk drops. It just up until recently, it wasn't felt that it was, so-called cost-effective
Right.
to do these younger people
Right.
because they weren't getting the disease. But we're finding out that indeed, 10% of all colon cancers, and last year up to 40,000, 50,000 cases of colon cancer are diagnosed each year. 10% of them, the math is 4,000 to 5,000
Starting
people were being missed because we were starting too late.
Couple of questions. So what are the risk factors for cancer? I mean, colon cancer, and you talked about this 29-year-old. You mentioned there's some genetics, so it sounds
Right.
like obviously there's some genetic. Are there other factors?
Yeah, other than family history, obviously. And
Right.
in that same vein, if you do have a family history, we like to start at 40 years old.
Okay.
And again, immediate family history, unless you have multiple
Immediate,
aunts
like
or
your
mother,
parents,
father, brother, or sister.
Okay.
Cancer or polyps is the immediate. Then it's at 40.
Okay.
If you have a number of uncles or aunts, or a number of grandparents, that weighs in as well.
Okay.
One grandparent per se isn't enough to say that you're at higher risk.
Right.
And there's also the age in which people get. So you have to kind of go through that with the patients and decide where do they fit. But risk factors besides family history, obesity,
Okay.
smoking increases it. Certain areas in the country are higher. I mean, we have pockets in Louisiana, Alabama. It's interesting that there's different spots along the Mississippi River that have higher increased associations.
Any theories on
And
that,
they're
or?
thinking there's contaminants
Okay.
from discharge into the Mississippi River.
Okay.
And one of the things is, why are younger people getting it now that weren't getting it before?
Right.
Is it related to toxins that are being ingested? Is it related to insecticides?
Right.
Antibiotic exposure.
Okay.
I mean, the big thing now, everybody talks about probiotics.
Right.
Are antibiotic exposures affecting the biogenome,
Right.
all the bugs that we have normally in our intestine, which are millions,
Right.
affecting people at younger ages because we're giving them antibiotics, either antibiotics in food that they're getting indirectly, and is that affecting their biogenome, which then may affect their ability to keep cancer at bay or not. Maybe it's affecting
Right.
them where they
Right.
get at a younger age.
Okay.
So all this is in the milieu.
In the mix with it also. Is it also something, I mean, I know there's some cancers, like in men, prostate cancer at a certain age, most, or a large percentage of men, just by virtue of aging. Is that a factor for colon cancer also? As you get older, does it become more likely?
Unfortunately, like most things,
Yeah,
as we get older.
exactly, yeah. Loss of hair.
Yeah, exactly.
Yeah.
Yes, unfortunately it is. As you get older, you're more likely to have polyps.
Right.
And so that, I mean, right now, the biggest group of people that I see colon cancer in are those in their 60s and 70s who've never had a colonoscopy.
Okay.
First time colonoscopy at, 72, have had bleeding or maybe anemia or something like that. That's cancer until proven otherwise, unfortunately.
Okay.
You know?
Well, that was going to be my next question. So what are the symptoms? Let's say you haven't had a screening or the 29-year-old. What are the things that somebody should look for that would make them want to go get tested?
Unfortunately, the main one is nothing.
Really?
The vast majority of people don't have symptoms.
Okay.
The ones we always worry about, like this young gentleman I mentioned before, he had bleeding on a daily basis and thought, it was, for a year, and
Right.
thought it was hemorrhoids.
Right.
That's all well and good when we're looking for lesions down low in the rectum, like we described before.
Right.
But higher up, all the way on the other side of the colon, a little bit of blood is going to get mixed in with stool. You won't even notice it.
Okay.
So you don't want to wait for symptoms, because at that point you've got probably an advanced lesion.
Right.
So the number one thing is no symptoms. You should be getting it, at the right time. But if you do have symptoms, the one we worry about is obviously bleeding.
Right.
Change in your bowels is not. People think it's very big, but it's not unless it's consistent.
Okay.
In other words, it's all used to be regular, and now every time.
Right.
You're not, because lesions don't get smaller. So if you're having a problem and then it goes away and then comes back, that's usually not an issue. It usually never goes away, the problem, because the cancer doesn't change in its size.
Right.
So bleeding, consistent pain,
Okay.
pain that's always in that one spot, doesn't go away, Those are the main ones. Then there's, blood tests. Anemia is probably the next biggest one.
Okay, that would be the silent bleeding. That
Right,
maybe
exactly.
You
they don't
see
know
it in
all of a
your stool
sudden, 2
necessarily.
years ago they had a normal blood count, and now they have, they're down by 30%.
Right.
And they don't even know it,
So, this person is screened, you identify a polyp, and you remove the polyp. What is the cure rate? Like, people always wonder, is that, what do you recommend then? I mean, if you've identified a polyp and removed it. And actually, could you just describe what is a polyp too? We hear these terms a lot, the lay people don't necessarily know.
It's a growth that it can be either flat like a pancake, or it can be what we call pedunculated, and I equate it like a maple tree, where the leaves on the tree are the tumor, and the trunk of the tree is where it connects, which is more than likely benign. And you cut the trunk, so to speak, and the polyp is gone, and like again, this young gentleman, his cancer was on the top of the polyp. We cut the trunk, and he's cured. There's nothing needed to be done further. I think the other question, though, is how do we get to that point? How do we get to the point of taking out polyps? What are we screening for now? Because there's newer things on the market for screening that were never available in the past. Although still the gold standard is colonoscopy. Other recommendations have come out to say that that's still the gold standard. It picks up 95% of colon cancers. Then there's this FIT test, fecal immunochemical testing, which tests for human blood in the stool. It's done at home, sent away, and that's
human
about
blood. What other blood?
Well,
I guess the food you eat.
But the reason, exactly, the food you eat. You're supposed to. So this test, you don't have to be on a special diet. In other words, stay away from red meat for a few days prior to the testing done. You can just go in anytime, and the stool is then tested for human blood. And that's about 80% effective in detecting cancers. And then the most common one that you see on TV these days is this Cologuard test, which is a DNA combination with a test for blood. And so what happens is it is about 90% effective in finding cancer. Only about 40% of the polyps, though, are found via this. And in that same vein, colonoscopy, if it's normal, it's every 10 years. If there's fecal immune testing, this FIT test, it should be done on a yearly basis, because it's only about 80% effective in finding cancer. And then the Cologuard test, which is all over the TV, is about 90% effective. Because of that reason, it should be done every 3 years. It's, you don't have to go through the prep and all, but if something is found, then you are going to have to prep and go through a colonoscopy. The problem with it is it does miss polyps, and it's only for people with average risk. No family history, like we talked before, mother, father, brother, or sister. It's not for someone who has had polyps. Because if you have polyps, you have a high propensity to have more. And it misses 40% of polyps. So if you already got a good chance you're going to have polyps, we don't want to give you a test that could miss polyps, because we know you've already make them. Chances are you're going to make more. So for people, it's only for average risk, and I see that sometimes people getting that Cologuard test when they really shouldn't be taking it, because they're not average risk anymore. Once you have a polyp, it's out for you. Once, if there's a family history, it's out for you. You need the better test, which is the colonoscopy test.
You still believe the colonoscopy?
Yeah, it's the gold standard still. It has been. It hasn't been replaced. Even virtual colonoscopy, which is still done. I think it's done at Stony Brook. Again, it misses polyps that are less than a centimeter. And there's a significant amount of polyps that are under 1 centimeter.
Why does the Cologuard miss? Is it just that the polyp's not developed enough? It has to be to a certain
Well, a
stage
certain
or
amount
something?
of the DNA. We don't know every single DNA defect in every single cancer. So it has the vast majority. I'm sure as time goes, they're going to add more, pick up more of these genetic defects. A lot of them we're just still learning about. So it's going to take the vast majority of what we know and look for them, spin it down, and if it's enough DNA material that matches the DNA defects that we know. Again, there are some we don't know. That's why it's not picking up, say, 100% of them. I think, who knows, in 10, 15 years, that may be the first line way to go.
Defense.
Yeah.
So When you go to a primary care doctor, or you see your doctor, they'll often do a fecal blood, take a little stool and check for blood. What are the, is that just a, you know, and if they're checking for that blood presence, and then they would refer to
Right.
To a gastroenterologist, I
Right.
guess, if they think there's
Although
an
that
issue?
test really is not even recommended. The routine test that was done, 5-10 years ago,
Okay.
This FIT test is pretty much taken its place.
Okay.
The problem with that test, the fecal blood test, the sensitivity is very low.
Okay.
It's nowhere near the 80, 90, 95% on the 3 tests that I spoke about.
Okay.
So it's better than nothing, and that's really what got Cologuard approved.
Right.
Cologuard, I mean, we were at a 60% screening 60% of the population.
Right.
Up until recently. And so everyone was saying, well, how do we get to 80%? The goal was to get to 80% of the population screening. And so this test came up. Why do people don't want colonoscopy?
Right.
Well, you're getting anesthesia, you have to go through the prep.
Right.
It's not
I don't want to take the time from work.
Yeah,
Right,
exactly.
right.
So let's try to get those people in the mix.
Right.
And so even though it misses 10% of cancers
Right.
and it misses 40% of polyps, it's better than nothing.
Right.
And so we'll try to do it 3 years. The question is, do people come back every 3 years to get that test? So that's what got it approved, and that's going to increase our ability to catch that extra 20% of people that weren't being screened.
Can you describe, I'm fascinated by when you're, just describe a colonoscopy, what you're actually doing there, and what is it, you're actually visually examining the entire inside of the colon? Or?
Yeah, I mean the colon is 4.5 to 5 feet,
Really?
and to look at it, you need to get prepped.
Okay.
Because if you look at your pinky nail, on the average, it's maybe 2 centimeters, 3 centimeters at best, depending on your hand size.
Okay.
That's a big polyp.
Okay.
A polyp the size of your thumbnail has probably got a 30% chance of cancer in it.
Really?
So, I mean, I remember when people would, I'd be called into the emergency room here because someone swallowed a quarter,
Right.
and they pass that quarter, don't even know it's in there.
Right.
All right? And as long as it gets past the 2 main spots where you worry about it hanging up, they're going to pass it and don't even know that they passed it.
Really?
So people aren't going to feel lesions that big.
Right.
So you need that colon to be pristine.
Okay.
So that's where the prep comes in. You have
Okay.
to clean them out so you're not missing something as small as your pinky nail. And there are
Right.
polyps that are even smaller than that, 1 or 2 millimeters.
Okay.
So to get that visibility, you really need to be pristinely clean.
Okay.
And there are new recommendations on how to get the best clean out, and so once they're all cleaned out, the next day they'll come to the they'll come to the hospital here,
Right.
and you'll get intravenous medication by an anesthesiologist.
Right.
It's not that way all over the country. Out west, they're still using conscious sedation where you're kind of semi-awake.
Right.
But we've been using propofol medication now here for well over 15 years, and personally, I've done both.
Right.
I've seen both, and I would not have it any other way.
No.
The patient doesn't feel a thing. They wake up.
Right.
It's over.
Right.
And we're now in the last 2 years or so, 3 years, using CO2. We used to inflate the colon to
Really?
distend the walls so you can see, because the walls will be crinkly, so to speak, and then when you inflate them, it flattens the wall out so you can see the lining and really very flat polyps.
Okay.
So we're now distending with CO2, which the body then reabsorbs, so people don't wake up crampy.
Okay.
They don't have to be, oh, I got all this gas I got to pass.
Right.
The body reabsorbs it and they feel nothing.
Okay.
So in and out of the
Used
hospital
inflate
2 hours.
with just air, or did?
Yeah, with regular room air.
Okay.
In the last 2.5 years, which pretty much most people have moved to.
Right.
We got that actually maybe from the laparoscopic people, because that's what they distend when they do laparoscopic surgery. They distend the bowel with CO2.
Okay.
And so the patient wakes up and doesn't feel it at all.
Right.
Yeah.
How long does it take, the examination?
The actual,
typically?
depending on what we find,
Right.
anywhere from 20 minutes to a half an hour.
Okay.
In and out of the hospital, 2 hours, walk in, walk out.
Right.
Get a cup of coffee, we give
Exactly.
we give you some juice
You're
or something to get
hungry
you ready.
one morning, but
Exactly.
you'll enjoy the dinner that night. Exactly.
Yeah.
So, and what's your recommendation in terms of, clearly now it sounds like 45, go in to have a colonoscopy at 45 years old and nothing's found, what then?
10 years. The current
10 years,
recommendations
okay.
are 10 years. Right.
Okay.
So again, getting back to this onerous prep,
Right.
I mean, if you could say, and there's studies to show that one exam, even in your whole life,
Right.
significantly decreases the incidence of your chances of getting colon cancer.
Right.
So if you think that one time in 10 years,
Sounds worth it to
we
me.
put a lot of other,
Yeah.
we do a lot of other things
Yeah.
more frequently that are more onerous than once out of every 10 years
That's
to
right.
really significantly decrease your chance of getting cancer.
That's right, and given the incidence of it, and
Yeah.
and it sounds so. What happens when you find the cancer inside after you've done that exam? Do you take it out on the spot while they're being examined, or what's
If
happening?
it's something large,
Yeah.
we're unable to. We now need surgical
Okay.
involvement.
Okay.
And it usually is not done right then and there.
Right.
So we'll usually then get, the patient will go home. We'll usually get a CAT scan
Right.
to make sure there's no spread, and then they're lined up with their surgeon, and then the lesion will be removed.
Okay. Okay.
And they're usually in and out of the hospital in a couple days. It's not like a week long anymore. Again, it's done all laparoscopically now. 10 years ago there was question whether laparoscopic was the right way to go
Right.
For cancer surgery. And now the results are just as good, or actually better, because they're getting home sooner.
Right. Much more minimally invasive.
Exactly, yeah.
And is it a process, in terms of the prep and the after people can go back to work pretty much the next day, right?
Oh, definitely, yeah.
Right.
Yeah, that day we ask them not to because they're under the influence of the medication.
Right.
We like them to get a ride home.
Right.
But the next day, fine, yeah. I tell people don't work out that day because they may be a little dehydrated from the prep and all that, and a little coordination-wise off. No work, and don't work out. Don't go home and decide, the afternoon I'm going to go to the gym.
Right.
Take it easy that day. Give yourself a break.
And how often, if somebody does have a history, or maybe if they found a polyp and you've taken it out, how often do they need to come back?
It depends on the size and the
Okay.
number. If there's a family history and there's no polyps found, it's usually a 5-year return.
Okay.
If there's only 1 or 2 small polyps, then it can be a 5-year return.
Okay.
If there's 3 or more, depending on the size, or I'll for a better term, I tell patients whether they was angry or not, because
Right.
and I get into the dialogue. I mean, I don't want to make it too, technical. If it starts to have some of these features that are suggesting it's on its way to become cancer, then they might come back earlier.
Okay.
Or if it was a flat polyp, like a pancake, and you have to scrape it out.
Okay.
Or you have to lift it. We have techniques now where we inject material underneath the polyp to raise it,
Okay.
so that we can get under it safely without the concern of perforation.
Okay.
All these are techniques that when I first started 25 years ago, we didn't even have them.
Right.
It's come a long, long way.
Yeah. I can believe
So it could be anywhere from 1 year. It could be a few months if there's a concern that you didn't get all of it, the polyp.
Right.
But on the average, anywhere from 3 to 5 years
Okay.
is usually return if you've had polyps. Again, if you haven't, then you're looking at 10.
Okay. And I know that this sounds kind of self-evident, but it sounds like clearly catching it earlier is better. What's the sort of progression? If why shouldn't people ignore these things? And
Well, again, like this young gentleman I had, he had cancer in this polyp. He's cured.
Right.
He's got a totally normal life expectancy.
Right.
The deeper that lesion goes through the wall, the lower is your survival.
Right.
It goes through the wall. It goes up, into the wall through certain depths, depending on the actual depth. It drops, 20% per depth, so to speak.
Okay.
Then if it gets into the lymph nodes, that's even worse. And then after that, if it gets into the liver or spreads to the lung, metastatic disease, even though we have much better chemotherapies,
Right.
but the morbidity and mortality dramatically increase.
So clearly makes a lot of sense to catch it early and to do that screening. Can you just talk about a little bit about some of the other advances that are happening in terms of some of the screening? I mean, typically the scope right now is this long snake-like thing with a little camera, and just some of the other advances I know that are being looked at in the field.
Well, there's, it's just like a TV, because we do watch this on a TV screen.
Right.
And everything is high definition.
Okay.
And, the next step is going to be 4K. And they're going to get to a point where we can look at a lesion like as if it's under the microscope.
Really?
Because we take things out that we're not sure is a true polyp, and we
Okay.
have to wait for the pathologist to give us an answer.
Okay.
We're going to be to a point where you're going to be able to look at that polyp and say, you know what, I can see like the pathologist can see
Right.
on a molecular, cellular level.
Wow.
And say this is an adenomatous polyp, it needs to come out.
Right.
This is not an adenomatous polyp, which decreases chances of bleeding and things like that, because if you
Right.
won't be taking out polyps that you could leave in place.
Right.
And we're not that far away from that at all. It's gotten down to where you can pretty much tell with the high definition we have now, but we're going to get down to a cellular level pretty soon.
And certainly with the technology we've available for seeing it, your clear recommendation, I'll just say it again, is get the scoping, take the time, go
Right.
get, not rely on home testing or some of these other things.
Exactly. Yeah.
Right.
And I think also a quick one thing I can put in, our facility here at the hospital for the last 6 years has been given the ASGE Quality Unit Award. For the last 6 years, they go through a multitude of things that we look at that allows us to get this quality designation.
Right.
It looks at the prep, how good preps are that when we bring our patients in, how well the patients are taken care of, whether it be from a nursing point of view, how the instruments are sterilized and cleaned, and it's a multitude of things that we look at. Sue Bond, who runs the unit and is a dedicated GI nurse, special training for that.
She's fantastic.
She's been running that for 10 years as a GI nurse and 20 years at the hospital. And we've had this designation for the last 6 years. A lot of places that go in their offices don't even look at those things.
Okay.
So that's another, an added benefit of having it in a facility like ours.
And I know that one of the things that you're required to do also is tracking, so that reminders every however many years.
Right.
So that
And the ASG, which is the American Society for Gastrointestinal Endoscopy, they're the ones who give out these quality unit awards, so to, I don't know if it's a true award, but it's quality units designated. I have 3 pages of things here that they look at. How many polyps we're finding, how do we take care of patients who come in with certain infectious things so that we are containing it and not being exposed to other patients. So it's a lot of work, and I think we should be pretty proud that the unit has gotten this designation 6 years in a row now.
Absolutely. No, it's a wonderful team there. And just the process, Dr. Naso, if somebody was realizing they need to get screened, do they have to go to their primary first, or can they make an appointment directly with one of the gastroenterologists?
They can make an appointment with any of us. There's myself, Dr. Georgopoulos, Dr. Khan, all affiliated here with the hospital. And you don't, unless you need it, depending on your insurance. And very often, not very often, but all the time, even if you called directly to us first, we check that out. And we say, yes, you can have this appointment, but you need a referral. That's the minority these days. But yeah, they can call the doctor's office, gastroenterologist's office directly and set something up.
Okay, wonderful. And I know we're just about out of time. I have one last question. I've seen some articles talking about decreasing the amount of screening as people get above a certain age. What's your opinion on that?
The current recommendations are we stop between 75 and 85. Those closer to 75 are no family history, who've had a few colonoscopies, and nothing has ever been found. Closer to 85, and I have patients 85 and sometimes even older, because I keep finding polyps every time we go back. They're polyp makers. And nowadays, I mean, when I started 25 years ago, we didn't see 90-year-olds. 90-year-olds now, I hate to say it, but they're a dime a dozen. There's nothing special about being 90 other than you made it. I see so many 90-year-olds. So the question is, these older patients who keep making polyps, have a family history, you got to keep an eye on them. Because they're going to hit 90. And they would, if they stopped at 75, they wouldn't have been screened in 20 years. So 85 is kind of the cutoff. We do it very individualized, depending on what we have found in the past with them.
And why would you stop? Just because there is like anything, there's a certain risk after
Yes, I mean, there are certain patients who I won't even screen at 75 because of lung disease or heart disease. They're on home oxygen and not going to tolerate the prep or the anesthesia. It actually goes with your longevity. It's all about risk and benefits, and is the benefit of colonoscopy, is the risk going to outweigh the possible benefit?
Great. Okay. And we are out of time, but thank you so much for this very, very enlightening discussion and recommendation that everybody get screened. I didn't realize it really is 100% of everybody at a certain point. It's making me realize I'm late with my last time I was screened.
I'll give you the number.
Yeah, exactly right. Thank you, Dr. Naso, and thank you and your team for all the great work you're doing here.
My pleasure.
And I'd like to thank all of you for watching us today. If you have any questions or would like to speak further with Dr. Naso or any of the gastroenterologists here, you can certainly call, and we'd encourage everyone during Colon Cancer Awareness Month to be in touch and follow the advice that Dr. Naso has given you, but please call 631-283-0090. As always, I'd like to thank our friends at CTV for producing and airing this show in our Southampton community, our friends at LTV for airing it in our East Hampton communities, and I'd like to thank all of you for watching, your suggestions. If you have any ideas for future programs or just need help navigating the healthcare system here in the East End, please feel free to call my office at 631-726-8555. Thank you, everyone, and good health.